Good afternoon. Thank you for joining the webinar. This webinar is about medication-assisted treatment in jails and community-based settings, and is one in a series of learning webinars for Justice and Mental Health Collaboration Program grantees and Second Chance Act Reentry Program for adults with co-occurring substance use and mental disorders grantees. My name is Mark Stovall. I am a program associate at the Council of State Governments Justice Center, and I'm excited to have two panelists with us today. Lisa Ramirez, lead program specialist at the Texas Department of State Health Services, Mental Health and Substance Use Division, and Rebecca Pugmire, director of the Division of Behavioral Health Services at the Washington County Health Department in Maryland. And we had planned to have a third speaker from Cumberland County, Maine join us, but unfortunately she is unable to join due to illness. And thank you to all of you who are joining us today. Before getting started, I'd like to briefly talk through a couple of housekeeping items about how this webinar will work. Anytime during the webinar, you can ask a question by typing it into the Q&A panel on the bottom right-hand portion of your screen. This includes both technical and content-related questions. We will try to reply to technical questions in the chat window as we go. For the content-related questions, we will keep a running list and address them all at the end of the webinar. We will do our best to get through as many questions as possible. If there are any unanswered questions at the end of the webinar, feel free to follow up with myself or with one of the panelists. If you encounter technical or audio problems during the webinar, please call WebEx Technical Support at 1-866-229-3239. Please understand that there are some technical issues you may not be able to resolve. For this reason, we are recording the content portion of this webinar. And the content portion will be available in about 2 weeks. You can feel free to email me for the link to the recording of the webinar. And lastly, although the webinar information indicates that we will go until 3:30, we may wrap up slightly early. Before getting into the details of medication-assisted treatment and how it has been implemented in these two jurisdictions, I would like to give you all a bit more background on the Council of State Governments Justice Center. The Justice Center is a national nonprofit organization that serves policymakers at the local, state, and federal levels from all branches of government that provides practical, nonpartisan advice and evidence-based, consensus-driven strategies to increase public safety and strengthen community. And just some explanation about the National Reentry Resource Center. Technical assistance for Second Chance Act grantees is provided by the National Reentry Resource Center, which is funded by the Bureau of Justice Assistance and managed by us here at the Justice Center, and provides support to Second Chance Act grantees and the broader field. We are constantly adding new content and resources to our website, and we send out a monthly newsletter that provides information about the latest research, funding opportunities, distance learning events, and other news about reentry. To sign up for this and other newsletters, please visit the link on your screen at the end of today's webinar. And for an overview of this webinar, first we'll do an introduction to medication-assisted treatment, then we'll talk about implementation of Methadone in Texas, and then implementation of Naltrexone in Washington County, Maryland. So first, for an introduction to medication-assisted treatment, when we talk about MAT, we're really talking about 3 medications that are approved by the U.S. Food and Drug Administration as a treatment option for opioid dependence or opioid use disorder. These medications are used in combination with counseling and social support, and the research evidence shows that these medications are most effective when they are combined with counseling and support. So these are a treatment option for individuals with opioid dependence. There are special considerations for individuals with opioid use disorder who are involved in the criminal justice system. When individuals are incarcerated, there's the potential for opioid withdrawal syndrome and challenges for managing the withdrawal. And upon release, there's the risk of relapse and overdose, which can sometimes be fatal, and return to incarceration due to continued criminal activity. So first, to talk about methadone, this medication is an opioid agonist that reduces cravings for opioids and blocks the euphoric effects of other opioids if they are used. And this medication is taken orally. It is administered by opioid treatment programs certified by the Substance Abuse and Mental Health Services Administration, SAMHSA, in accordance with 42 CFR Part 8. And the research evidence shows that starting methadone maintenance during incarceration compared to after release is associated with higher rates of treatment initiation in the community. Next, buprenorphine is a partial opioid agonist that requires a lower maximum dose than methadone, and it doesn't produce euphoria or withdrawal, so it acts on the brain in a slightly different way. This can be combined with naloxone to prevent misuse, and some of you may recognize naloxone as the opioid overdose antidote. So in emergency situations, naloxone can be administered to individuals who are experiencing overdose to help prevent fatalities. Buprenorphine can be taken orally. It goes by the brand names Suboxone, Zubsolv, or Bunafil. It can be prescribed as part of an opioid treatment program or by physicians who have completed 8 hours of training. And the research evidence shows that rates of relapse and rearrest for jail inmates on buprenorphine are similar to outcomes for jail inmates on methadone. And then finally, naltrexone, this is an opioid antagonist, and it binds to the opioid receptors in the brain to block the euphoric effects of opioids. And it's worth noting that this medication can also be used for the treatment of alcohol dependence or alcohol use disorder. It can be administered as a tablet or by intramuscular injection. And there's no potential for misuse. It can be prescribed by healthcare providers licensed to prescribe medication. This is not a controlled substance, so there are no special regulations outlining the prescribing of this medication. And a pilot controlled study found that there were lower rates of relapse for inmates who began naltrexone treatment pre-release compared to those who did not receive the medication. And just quickly to pull the audience, just to get a sense of who is attending the webinar and where people are along the implementation spectrum of medication-assisted treatment, we wanted to ask where your agency is based, whether that's jail, community, or both. If your agency uses medication-assisted treatment, and if your agency uses MAT, which medication option do you use? And so on the right-hand side of your screen, you'll see the poll questions panel, and you can just simply click your selection and hit submit. And for those of you who may be watching on the same computer, but if there's multiple people in the room, just feel free to choose the response that makes the most sense to you. And we'll give it about a minute for folks to select their answers. So thanks to those of you who have answered the questions. I think we're able to see the results really quickly on the screen. Great, so there on the right-hand side, in the lower right-hand panel, you can see the answers to the question. So it looks like about 17% of folks on the webinar come from a jail setting, 20% are community, 14% are both, and then 42% NA. And then for whether your agency uses medication-assisted treatment, it looks like about 31% yes, 25% no, and then about 44% not sure. And then for which type of medication-assisted treatment, it looks like 8% buprenorphine, 3% methadone, 17% naltrexone, 3% other, and then 69% no response. So thank you all for completing that question. That really helps to give us a sense of who's on the line and who's implementing MAT and which type of MAT you're using. And so moving along, we have Lisa Ramirez to talk about implementation of methadone in Texas. Lisa Ramirez is lead program specialist in the Substance Use Disorders Program Services Unit for the Texas Department of State Health Services, Mental Health and Substance Use Division. Lisa identifies, plans, develops, and implements substance use disorder policy and initiatives. One accomplishment toward this endeavor includes the appropriation of funds during the 84th legislative session for a multi-million-dollar project aimed at improving outcomes associated with prenatal opioid exposure and neonatal abstinence syndrome. She served as both Women's Services Network Coordinator and primary subject matter expert on issues related to treatment and intervention services for pregnant and parenting women. Focused on improving outcomes for families affected by prenatal substance exposure, she served on SAMHSA's Center for Excellence expert panel on fetal alcohol spectrum disorders, SASD. As program director for the Pregnant and Postpartum Intervention Program in South Texas, her work aimed at improving birth outcomes and increasing family preservation for pregnant and parenting adolescents and adults with or at risk for developing a substance use disorder. She served as chair over the course of several years for the Nueces County Family Drug Treatment Court. Ms. Ramirez has her counseling experience in withdrawal management, residential outpatient intervention, and outreach settings. She earned her master's degree in art psychotherapy from Southwestern College in Santa Fe, New Mexico. And Lisa, I'll turn things over to you.
Thank you. So today I'll be discussing Texas strategies to address care for pregnant and postpartum opioid-dependent inmates in Texas county jails, and how the Texas Department of State Health Services formed a partnership with the Texas Commission on Jail Standards to provide medication-assisted treatment, primarily methadone, in addition to adjunct services to incarcerated women. So I just want you to kind of take a little notice. We have Texas is large, and we have quite a few counties in Texas, 254 to be exact. And if you'll notice under the D in opioid, there's a county spelled B-E-X-A-R, pronounced Bexar County. That's where San Antonio, Texas lies. And right next to it, there's a county called Guadalupe County, if you can read that. And I'll be discussing primarily these two counties in our discussion today. All right, so DSHS's involvement with the Texas Commission on Jail Standards really began with the case of Jessica Jessamy. She was detained at the Guadalupe County Jail, and the advocacy and involvement of national advocates for pregnant women, SAMHSA, and a local Texas judge really is what resulted in an invitation for DSHS to participate in the Texas Commission on Jail Standards Pregnant Inmate Care Committee and started the discussion of access to medication-assisted treatment for pregnant women. So this case received quite a bit of headlines and news coverage, media coverage. As you can see by the headlines listed here, Jessica is a military veteran who was self-medicating her symptoms of post-traumatic stress disorder and anxiety with opioids and discovered that she was pregnant. So when she discovered she was pregnant, she initiated treatment for her opioid use disorder and was provided with counseling and prescribed methadone. But she was later taken into custody for a parole violation that occurred prior to engaging in treatment, and she was incarcerated pending a decision on the status of her parole. So there were two expert affidavits that were submitted explaining the medical risks of denying medical treatment because Jessica knew that the policy of the Guadalupe County Jail was to detox inmates from methadone. So she was eventually detained and allegedly denied the methadone that she had been stabilized on, potentially increasing her risk of miscarriage because, as we know, the repeated fluctuations of short-term opioid use poses a risk to the fetus, and really the biggest risk to the fetus in this scenario is withdrawal. So with methadone allows for a stable, long-term, long-acting dose of opioid to keep the fetus stabilized. So with the advocacy from National Advocates for Pregnant Women, she eventually received her medication, and the parole board eventually released her with electronic monitoring. So if she had been detained to Bexar County Jail, these things would have looked very different for Jessica, because in neighboring Bexar County, we have a model program of integrated and collaborative care for pregnant opioid-dependent women. And by the way, Bexar County accounts for 1/3 of Texas cases, Medicaid cases, for neonatal abstinence syndrome, which is the set of symptoms that occur in a newborn when they've been prenatally exposed to opioids, which, by the way, is very treatable. So the hospital system in San Antonio, University Health System, and our DSHS-funded medication-assisted treatment provider, Center for Healthcare Services, have a collaborative partnership with the Bexar County Jail to provide medication-assisted treatment, as well as adjunct services such as a patient navigator who provides care coordination and education to pregnant inmates with substance use disorders. And the education includes what they call the Mommy's curriculum that is specifically tailored to this population. So at the time, we at DSHS and the Substance Use Disorder Unit were exploring ways to increase access to medication-assisted treatment for all pregnant women and women with dependent children through an exceptional item presented to the Texas legislature for approval. And about the same time, there was also a bill introduced to track miscarriages in Texas county jails. So both the bill was enacted and the exceptional item was approved. And so just to give you an idea of the scope of the issue, we've received some data due to that bill that was enacted tracking miscarriages. So there are approximately 400 pregnant women or women that are arrested that are pregnant in Texas county jails every month. So we average about 400 women who are pregnant. And then 5 reported miscarriages on average per month. So the Texas Department of State Health Services Substance Use Disorder Unit and the Texas Commission on Jail Standards, we partnered to create increase access to medication-assisted treatment and adjunct services to jails provided by our pregnant and postpartum intervention programs. So the Texas Commission on Jail Standards hosted a presentation by DSHS in May, and they continue to support our collaborative partnerships among the DSHS-funded pregnant and postpartum intervention program providers, our neonatal abstinence syndrome opioid treatment service providers, and the local county jails. So the role of the county jail is to provide a referral to these DSHS-funded behavioral health care services and open up access to these services for pregnant and postpartum women who are detained. So our neonatal abstinence syndrome opioid treatment services include methadone, counseling, and the medications are delivered and administered every day to eligible inmates by staff from the OTS program, and it is at zero cost to all eligible pregnant and postpartum women in the county jail system. And when we say postpartum, we mean up to 18 months postpartum. And our pregnant and postpartum intervention programs provide motivational interviewing, case management services, which includes coordination with Child Protective Services, our child welfare system, the local hospital systems. They provide education that includes the Mommy's curriculum that I referenced. It's a 16-session curriculum that is specifically tailored to this population that addresses several key issues that range from prenatal care to parenting and infant and child safety. It includes overdose prevention education, which we know is so important, especially as individuals are leaving justice systems, outreach, home visitation, transport, risk reduction education and materials. These services are free of charge, and they're also, the services are co-located with the neonatal abstinence syndrome opioid treatment services, so they're working in collaboration with each other daily. So currently we have 18 NAS opioid treatment sites that have applied for these services, and we have 19 PPI programs already in existence that serve 36 counties. And we've had a lot of interest from several county jails. So currently, our role at DSHS is to meet with interested jails to understand their unique needs and to assist them in forming partnerships with our DSHS-funded pregnant and postpartum intervention programs and the NAS opioid treatment services providers. And so we recently visited our Travis County Jail, which is here in Austin, and they were doing a really great job in partnering already before this program, before we kicked off this program. So they're already doing a really good job partnering with their local DSHS-funded opioid treatment services provider to provide medication-assisted treatment services, care referrals, parenting classes, et cetera, to pregnant women in jails. However, when we spoke with them, even though they were doing a great job in providing comprehensive services, they mentioned that they were still detoxing postpartum women. And they also recognized and identified a need for increased case management services for the women, especially when they were leaving. And they were very interested in overdose prevention education. And so with this new partnership, they're willing to consider offering medication-assisted treatment to women who were 18 months or less postpartum. And if you would like more information about the Mommy's curriculum or in this particular program, there are more resources available at the DSHS NAS webpage. And I will hand it back over. Thanks.
Great, thanks so much, Lisa. And then just to introduce our next speaker briefly, Rebecca Pugmire is the Director of Behavioral Health Services for Washington County Health Department in Hagerstown, Maryland. The division provides prevention, intervention, community, and corrections-based treatment and recovery services to individuals with substance use and mental disorders, as well as providing 2 statewide residential treatment programs for adolescents and women with children. In 2010, the division was a recipient of the Second Chance Act grant for family-based prisoner substance abuse. And in 2013, under Ms. Pugmire's leadership, the division received the Science to Service Award for office-based opioid treatment from the Substance Abuse and Mental Health Services Administration. And you'll hear a little bit more about that in Rebecca's presentation. Ms. Pugmire has 37 years of experience in the public health field, specializing in behavioral health services. She received her master's in business administration from Prosperity State University in 1998. She is a licensed clinical alcohol and drug counselor, nationally certified master addiction counselor, and substance abuse professional. And so, Rebecca, I will hand things over to you.
Okay. Can you hear me, Mark?
Yeah, I can hear you.
Okay, good. I just want to make sure. So in October 2010, the Washington County Health Department Division of Behavioral Health Services received a Second Chance Act grant for family-based prisoner substance abuse treatment from the U.S. Department of Justice. With the funding, the division provided pre- and post-release reentry case management and family reunification services to individuals in the local detention center. During the program's implementation stage, the program sought funding from the State of Maryland Department of Health and Mental Hygiene, Alcohol and Drug Abuse Administration, now known as the Behavioral Health Administration, to implement medication-assisted treatment within the detention center. Currently, there was no medication-assisted treatment at all in the detention center. So the program goals were to decrease recidivism, increase engagement and retention into the community-based behavioral health treatment, and reduce opioid overdoses. Prior to the implementation of the program, we were averaging about 50% re-engagement into community-based behavioral health treatment. You'll see the results of our efforts at the end of this presentation. So a month later, the division held a meeting introducing the use of medication-assisted treatment using extended-release Naltrexone, known as Vivitrol, for the treatment of alcohol and opioid dependence. The division invited the local detention center and the detention center's medical provider to the presentation. The next month, the division held a planning meeting with the two parties to implement a medication-assisted treatment program. The Washington County Health Department Division of Behavioral Health Services, governed by the state of Maryland, was the lead agency and coordinated the program services in collaboration with the detention center, Washington County Detention Center, and at that time it was ConMed Healthcare Management. It has now changed to Correct Care Solutions. Correct Care Solutions purchased ConMed, and then of course the Alcohol and Drug Abuse Administration. Existing program components that were in place and added to the success of the program were the established jail-based treatment for substance use disorders, an established outpatient treatment for substance use disorders, an established outpatient medication-assisted treatment, and a prevention program offering parenting services. Keep in mind that this was a family-focused treatment for individuals incarcerated, so that the prevention component was important. So the program components consisted of pre- and post-release behavioral health services, substance-related and mental health disorders, telemedicine through the use of video conferencing, medication-assisted treatment using Vivitrol, criminogenics assessments using the LSIR, trauma-informed parenting that happened at pre-release, structured video family visitations, family needs assessment using the FAST, the Functional Assessment Screening Tool, parenting services using the Evidence-Based Strengthening Families Program at post-release, incentives for participants or participation in the parenting services post-release, and care coordination. The program employed a recovery coach, a systems navigator, and partnered with an existing wellness center to provide community resources, i.e. employment, housing, transportation, child care, vocational, educational, and mutual support programs. The following program components separated this program from other reentry programs, and that was the structured video family visitation. The program provided monthly visitation for the children of the justice-involved individual via video conferencing. We had telemedicine. In order for the department to prescribe medication, the individual must receive a medical evaluation by the prescribing physician. The department's physician conducted a face-to-face medical evaluation with the incarcerated individual through the use of video conferencing after reviewing the medical provider, the detention center's medical provider's medical assessment. And then medication-assisted treatment. The program provided alcohol and opiate-dependent individuals an opportunity to receive extended-release naltrexone pre- and post-release. And Mark went over what naltrexone is. It's an extended-release medication. Vivitrol is the injectable. It is an antagonist. It's non-addictive, non-narcotic treatment for alcohol and opiate dependence. One of the issues that behavioral health professionals struggle with is medication compliance and diversion. This medication seems to put these two issues to rest. Extended-release naltrexone requires the opiate-dependent individual to be opiate-free for 10 days before using the medication. Offering this medication to opiate-dependent individuals while incarcerated prior to release is critical, since this may be the only time the individual will be opiate-free, totally opiate-free. So, medication-assisted treatment begins with the clinician conducting a biopsychosocial assessment to identify alcohol or opiate dependence. The program targeted individuals incarcerated in the local detention center that had multiple convictions as a result of their substance dependence and had failed traditional treatment experiences. The clinician meets with the appropriate identified individual and offers pharmacotherapy. And the only pharmacotherapy available, or medication-assisted treatment available at that time for us, was the Vivitrol. The clinician obtains the individual's medical record from the detention center's medical provider, forwards it to the department's medical director. The clinician schedules a video conferencing session between the individual and the prescribing physician. The prescribing physician orders the blood work. The medical provider draws the blood work, and the prescribing physician reviews the test results and prescribes the medication. Some coordination regarding the date of the injection is necessary. One of the barriers that we ran across were the local detention center regulations require medication and needles to be stored separately. Complying with that regulation would breach the integrity of the kit. Therefore, the medication is stored at the local health department and is transported to the detention center on the day of the injection, which has not been an inconvenience. We have not had any problems with that at all. The clinician will verify the individual is drug-free before receiving the injection by doing a rapid drug test. And the detention center's medical provider administers the injection. That was how it started, and since that, it's 5 years. Moving forward, 5 years later, we no longer do the video conferencing or the video evaluation, medical evaluation. The detention center medical staff now prescribe the medication. So, and I'll talk about that a little bit here when we go over program challenges. The program faced many challenges. Here are a few of the more significant ones. There were 3 entities, a local government, a state government, and a private provider coming together to partner to implement this program. So obtaining a fully executed qualified service organizational agreement took about a year to get that resolved. And I know now that it would we could shorten that a little bit, but just staying on top of that, getting that processed, was time-consuming. So prescribing the medication, Vivitrol was not approved by the FDA for the use of opiate dependence until October 13, 2010, and April 13, 2006 for alcohol dependence. The medication had never been used within the detention center or a prison setting. In that respect, the medical provider, the detention center's medical provider, was hesitant to prescribe the medication. That's what forced us to do the video conferencing for the medical evaluations. Washington County Health Department was the first in the country to use Vivitrol in a detention center setting. In addition, the Health Department has worked with 10 other counties in Maryland to replicate this program, and also has worked with Barnstable County, Massachusetts. In 2013, Barnstable County, Massachusetts replicated the program, and it is now in 9 state prisons in Massachusetts and 11 out of 13 counties correctional facilities. Release date from the detention center. In Washington County, release date was very fluid and hard. It was complicated by the timing of the injections. It made it difficult for us to give an injection prior to release. An individual can attend a court hearing. The judge would release the individual directly from court. And so therefore it made it very difficult for an individual just to get one injection right before they left. But that since has been resolved, and the detention center staff are more involved in calculating the release date, and we have now narrowed it down to one injection 1 to 2 weeks prior to release. Coordinating services once the individual is released from the detention center. Because the release date is not always carved in stone, it makes it difficult to schedule an individual for a follow-up community-based service for their next injection. But as I said, we were able to resolve that. I would say in the last 6 months, we have resolved that. Enrolling the individual for health benefits. Continuity of services is essential for an individual being released from a controlled environment, but the lack of health care benefits makes it even more difficult. The division accesses a systems navigator for screening and enrollment. To screen and enroll eligible individuals in Medicaid, thereby ensuring that the individual will have a health care benefits upon release. So the funding for the program ended in September 30th, 2012. The department was able to sustain the following program components: the behavioral health services, the telemedicine, which has now went away because there's not a need for it, but medication-assisted treatment, care coordination, and recovery services. And I should add there, systems navigation has improved, connecting people with health benefits. So the results after 1 year, 21 individuals participated in medication-assisted treatment over that 1 year. 92% receiving medication continued in treatment upon release. Keep in mind that I said earlier in the beginning of the presentation, about 50% were continuing in treatment upon release, so we had a significant improvement there. 80% of those individuals remained in treatment 90 days or longer, and then 85% reported a reduction in substance use. So results after the second year, 44 individuals participated in medication-assisted treatment. 75% 18 of those individuals receiving medication continued in treatment upon release. 82%, 28 individuals remained in treatment 90 days or longer. And those numbers may look a little funny, but it's because we were also doing we were also implementing Vivitrol in outpatient by that time. So all those numbers were put together. So that's why you see the 82%, 28 people remaining in treatment 90 days or longer. 8% tested positive. That was 2 individuals for substance while in treatment, while receiving Vivitrol, and 1 individual received 4% a legal charge while in treatment. So we ran some numbers in December of 2015, and 92% participating inmates have not returned to the detention center 1 year after release. And then Mark had said earlier that on May 20th, 2013, the division was awarded the SAMHSA Science to Service Award for office-based opiate treatment. The division was one of 5 recipients in the country to receive this award, and more information can be found about the program by going to SAMHSA's website and search for 2013 Science to Service Award recipient. Thank you.
Great, thanks so much, Becky. So there's actually not a placeholder for Q&A in the webinar, but this is the time for Q&A. So if you have a question, feel free to just chat it in that box, and then we'll ask the question. Just one question for Becky, just going back to the last thing you mentioned. Can you just talk a little bit more about training other counties in Maryland on medication-assisted treatment?
Sure. It was late, I think it was late last year, maybe around July of last year. The governor released $500,000 for detention centers to replicate the Washington County program. And so I have been going to the various counties, and every county is different. I have not run across one county that does it like anybody else. So what I do is I meet with those individuals and listen to how they're set up, and then I make recommendations, kind of offering consulting services in a sense that, or help them work through the processes and develop a program that they're able to implement. So, and as you can see in the beginning, after the first year, I forget how many I said that we had, 21 or 22 people. It's this program is very slow to take off, but once it does, it's very popular. I think we have given over 400, close to 500 injections to close to 175 individuals.
Great, thank you, Becky. And then this question is for Lisa. Lisa, how was methadone chosen as the MAT option for these women?
It was chosen because methadone is considered the gold standard for pregnant women at this time, although buprenorphine is also looking promising under certain circumstances for pregnant women. So our NAS opioid treatment service providers can offer both methadone. They do offer both methadone and buprenorphine, but primarily for pregnant women, methadone is still preferred, especially for women who were not previously maintained on buprenorphine. So those women who are maintained on buprenorphine prior to becoming pregnant would stay maintained on buprenorphine, but for those women who are either maintained on methadone or who were using illicit opioids would then be placed on methadone. And generally speaking, obviously, each individual physician at the opioid treatment site is going to make that final determination. But primarily for pregnant women, the preference seems to be methadone.
Great.
Mark?
Thanks, Lisa. Yeah.
I'd like to add something to that previous question. The other thing that I offer these counties, and as well as I've worked with close to 15 different states, is I have a sample MOU, a contract and consent to treat, and a medical evaluation, and a standard of operation that I share with each of those counties and other states so that they don't have to reinvent the wheel, that they're able to take those documents and adapt them to their own business practice.
Great. Yeah, I'm sure those resources will be really helpful. Would it be possible for you to send some of those to folks if they have questions about those resources for you after the webinar?
Yeah, they can email me, and I will send electronic documents so they can modify them in any way they want.
Okay, perfect. And then Becky, just a parallel question for you is, how was Naltrexone chosen for this population and at that time?
Naltrexone was chosen, the jail does not, the detention center does not do any, as I said earlier, any medication-assisted treatment. Individuals were going in there and detoxing pretty much with no assistance at all, and they still do. But so for us to bring them to the table, the detention center, and for them to be interested in a medication-assisted treatment at all was really a win and a foot in the door. And it started out by educating the judicial criminal justice system and the policymakers that it was a non-addictive, non-narcotic, non-scheduled medication that did not require special training or special certification to give. And so that seemed to be something that they, and it's not diverted, can't be diverted. And that was the educating the public and the policymakers that seemed to be the winning ticket.
Mark, this is Lisa. I just wanted to add about the methadone piece. One thing that we really had to do was to build in a reimbursement system for our NAS opioid treatment service providers who are delivering the methadone and watching each person. They administer the dose. They're watching the person swallow the dose of medication so that there isn't any risk of diversion, and the jail does not have to take upon the burden of storing the medication, et cetera. So we had to create a reimbursement system for their time to travel to the jail every day to deliver the medication. So we knew that we needed to, make sure that we were compensating the opioid treatment providers for providing that daily service and monitoring and delivering the dose.
Thanks, Lisa. Yeah, that's a really important point. And then another question is, how many counties is this going to be rolled out in Texas?
Well, so far we have 18 OTS providers, opioid treatment providers, interested in providing these services, and we're still facilitating those collaborations with the county jails. So, but we're still enrolling opioid treatment providers throughout the state. There are 85 licensed opioid treatment providers in the state of Texas. The opioid treatment providers, in order to be eligible for this program, must be willing to, or must be enrolled as Medicaid providers as well. They must be willing to have our pregnant and postpartum intervention program co-located to provide the adjunct services. So we're still rolling this out, but certainly no more than 85. And at this point, like I said, we have 18 interested with 19 PPI programs covering 36 counties, and these 18 opioid treatment providers can deliver to surrounding counties as well. So as long as we're getting buy-in from our local county jails, then, you know, the sky's the limit. Hopefully as many as possible. You know, this is so important, you know, not only for reducing the risk to the fetus during pregnancy, but of course, when we are maintaining someone on medication-assisted treatment throughout their time they're incarcerated, upon release, if they can just easily transition into their state-funded program in their community, which is, you know, what should happen in this scenario, we really reduce the risk of overdose. And when we talk about overdose in Texas, overdose is the third leading cause of maternal mortality for women in Texas, so, and especially among this population. So, so we're really trying hard to make those help assist with those partnerships becoming concrete.
Thanks, Lisa. And then, Becky, just a question for you. Were there any challenges once folks were released into the community and enrolled in Medicaid? Were there any challenges with Medicaid payment for Naltrexone?
The first visit, sometimes there were a couple challenges, but the first visit, getting their benefits activated in a timely fashion that you could get the authorization, but that was really, you know, that's really on us to do that a little quicker. So let's just say somebody gets released on the 1st, and their next injection would happen. We always tried to give them at least 3 weeks, but sometimes it's 2 weeks. But when they would show up, if for their appointment, then the doc would have to jump through some hoops to get that authorized. But Alkermes uses a system called touch points, and once we had that in place, it seemed we implemented, we used that, and we also put a systems navigator. And how this works is, in Maryland, of course, their MA is not activated until they step outside of the detention center. But we would use a systems navigator to get all the information and then enter it into the system, and then it was on the patient or the inmate to show up within 24 hours of getting released to activate that their benefits. And that goes back to educating to the individual, educating the individual on the importance of medication or benefits, medical health benefits. And so, it takes a lot of educating them for that. One of the things that we did run into was MA wanted to start treating it like a buprenorphine, and that it says every 30 days, the patient information and the information about doing injections every 30 days. And so, but you really try to get that patient in here on the 28th day, because the medication really diminishes after the 28th day. And what would happen is medical assistants wouldn't approve it because it wasn't 30 days in between the shot. So I worked with Medicaid to change that policy in Maryland, and they just weren't aware. They, that how they were basing it on like buprenorphine, that it's every 30 days, and so we were able to make that policy change. And MA pays for the medication pretty with no problems. Private insurance, you have to argue a little more, and fight that battle of paying for that medication versus paying for an inpatient opioid overdose, or an ER opioid overdose, or a detox. So it'll take time, even though it's been around for a long time. Insurance wasn't reimbursing, but I would say in the last 2 years there has been leaps and bounds changes in healthcare benefits.
Great, thank you, Becky. And then, Lisa, we have another question for you. Is compliance on methadone ever an issue for the women?
Well, as I mentioned, we're just getting these programs started, but I haven't, from the programs that have been providing these services, I mean, we're talking about pretty much short-term stays in county jails. So, so no, I have not heard of any compliance issues with the pregnant inmates in the jails. I think what we're hearing more of from our, for example, our pregnant and postpartum intervention program providers and our other providers in the communities are more of an issue of lack of access to the medication once a pregnant client enters the jail system. So I haven't heard of anything yet, but again, we're just getting these programs off and running. So.
Thanks, Lisa. So it's just a little after 3, and we actually don't have any more questions. But just before we wrap up really quickly, here are some links for additional resources on medication-assisted treatment. And so these explain both the science of the medications and implementation issues for MAT. And so these are the links, and then I'm happy to follow up with folks individually with additional resources for MAT. And also, just wanted to thank you all for participating on the webinar today. A big thanks to Lisa and Rebecca, and thank you all for joining. And then here are email addresses for Lisa, Rebecca, and myself.
Thank you, Mark.
Yeah, thank you so much.
Thanks, Mark.
Take care and have a great day, everyone.
Okay, bye.
Bye.